Welcome to the last lecture of this course for the summer. I'm excited. That's why I'm wearing my really robust brown polo, because the topic we're going to be talking about is exciting enough. I don't need to wear a big, multicolored Hawaiian shirt to keep your attention. Healthcare economics should do it for me. We're going to talk real quickly about some of the factors that are facing healthcare now. The biggest one is money. Increasing costs, it's killing healthcare. It's killing the country. President Obama and the Affordable Health Care Act hopefully will start to get some control over this. Don't know if it's going to work. It's new. Managed care, I can't say that. Managed care is being used more and more to help control costs, and there's many different ways of doing that. There's a shortage of nurses. It's not as bad as it was about a decade ago, but in 5 to 10 years from now, it's going to be terrible. The shortage will be very pronounced, and at the same time, there'll be more older people to take care of. A double whammy. So how does managed care change reimbursement patterns? See, managed care is methods of controlling costs, managing care. In the early to mid 1900s, most people did not have insurance. If you went to the doctor, you just paid on the spot. And that was the norm. You pay. The physician was a businessman like anybody else. A lot of doctors had offices in their home. You went there, got treated, paid the money, went home. By the mid '60s, when Medicare and Medicaid started insurances became more and more popular, especially insurances provided by employers. So that changed a lot. No longer did you have to count out money to pay the physician. You went to the doctor billed the insurance company paid the doctor, and you never really had to worry about the cost. That changes things. Think about how that would be if you were shopping for iPhones or computers or a car. There's no price tag anywhere. You just go get the one you want and somebody else pays for it. How would that make your choices? How would that affect your choices? Would you want a flashier car? Would you want an extra car? Would you want a new iPhone every time a new one came out? It's kind of what happens sometimes with healthcare. People don't have to really worry about the costs. And that's what started to drive healthcare prices up. Demand drives prices up. When it's supply and demand. When there's more people that want it, they can charge more for it. So some things began to help control those costs. And there's two common forms of insurance plans. HMO and PPO. HMO and PPO. I hope you can see that. I don't think you can, though. Let's try a different color. What's the difference between an HMO and a PPO? Well, they have very different perspectives on what's important, but the bottom line is they both function as insurance companies. So there is a lot of overlap, but there's a lot of difference too. Let's talk about HMOs, which were really popular in the 1980s and 90s. They've kind of fallen out of favor a little bit, especially here in the Midwest. They're still very popular on the West Coast. HMOs are health maintenance organizations. Health maintenance organizations. So a health maintenance organization will probably have a focus on what? Prevention. Prevention. Their idea is to keep a person's health maintained rather than let them get sick and then fix them. How do they do that though? And how do they maintain control of costs? Because preventing illness has costs too. Well, HMOs have a very unique method of getting paid. With most insurance companies, there's a monthly or annual premium. And if you have employer provided insurance, your employer is paying a lot of money every month for insurance. Health maintenance organizations charge, it's called capitation. Capitation, or cap per head. They charge by the head. And what that means is an HMO, let's say we have Fred's HMO. Fred's HMO is going to provide healthcare coverage for John's bar. I couldn't think of anything else. John's Bar. John's Bar has 100 employees. It's a big bar, popular place. Fred's HMO goes to John's Bar and says, we can provide all of your healthcare coverage. We're going to charge you $1,000 per person per month. Sounds like a lot, but that's actually a pretty good price. So 1,000 people times $1,000. Can you do the math? Sure you can. $100,000. Now, here's the thing though. John's Bar will pay Fred's HMO $100,000 a month to provide health care to John's 100 people. That's all that anybody will pay Fred's HMO. If 100 of those people, if none of them go to the doctor that month, they're all healthy, Fred's HMO makes $100,000 and spends none of it on health care, right? If 10 of those people have heart bypass surgeries at the cost of $50,000 each, that's a conservative estimate. Let's do some math here. 50,000 times 10, $500,000. Those 10 people cost the HMO $500,000. The HMO is still only going to get paid $100,000. That's capitation. They agree to provide coverage, all coverage, for a flat fee every month, no matter what happens. So some months, they're going to make it. They're going to make a big profit. Other months, that's going to kill them. But over the time, it averages out, or at least they hope. So why would any place want to risk that much? Well, they're not really risking that much. They do a pretty good job of determining probable expenses. So, are they gambling? A little bit, but not a lot. So let's look at a little bit more though. How does the HMO make sure that they don't spend more than they have to? Well, HMOs have what's called a gatekeeper. Whatever, we're going to spell it like that. A gatekeeper is a primary care physician. And when you get sick, the first person you see is your gatekeeper, your primary care physician. And they will take care of everything for you. They will do everything unless you need a specialist. And then the gatekeeper will allow you to go to a specialist. See, in some insurance plans, you can just go anywhere and see anybody, even if you didn't really need to see someone. For example, my wife's insurance company at one point said we could see anybody at all. They recently put in a rule where dermatologists, you have to have permission to go to a dermatologist, because a lot of things that the dermatologist does can be done by a primary care physician. So that insurance company is kind of putting in gatekeeper restrictions. But in an HMO, this is the first step in controlling costs. Everybody must use the gatekeeper. That's step one. Step two. Now, they get paid one flat premium a month, regardless of what they do. So if you only have $100,000 in this example of monthly income, are you going to spend it willy-nilly on tests, every test under the sun? Probably not. So you're going to have very focused evaluations. If you go in with a specific complaint, you might get a very focused but limited exam just of that one area. They won't look at lab work for your entire thing. They will look at just the labs that are being affected by what they think is going on. They will not immediately schedule you for a CT scan. They're going to start you with an X-ray first. They're going to step it up, spending as little as possible until they get the answers that they need. You will get good care, but it's going to be focused, it's going to be measured and careful. What else do they do? Well, the big thing is their network. Network. That is their primary method of controlling costs. Remember, you have a gatekeeper, and for everything that goes wrong, you see your gatekeeper first. And then if the gatekeeper can't handle what is going on, they send you somewhere else within their network. So an HMO will have a representative of every specialty in their network. As long as you go to somebody within their network, you have coverage. You have 100% coverage, no additional charges at all, period. You can see a dermatologist, a cardiologist, a neurologist, a psychologist. You can see whoever is in their network. And as long as you have permission from the gatekeeper, no charges. None. Nada. That's nice, isn't it? Now remember, you have to have permission to get to those specialists. So let's say you have knee pain. You're going to go see your primary care physician first. You're not going to immediately go to an orthopedic surgeon. He or she will treat you first. If they can't treat you, they will send you to the network orthopedic surgeon, who will not do surgery immediately. They will try less aggressive, less invasive treatments first. So, the network. Now, can you go see anybody you want? Sure. This is America. You can go anywhere. You can see any doctor you want. It's your choice. However, there is one stipulation. When you're in the network, when you go see the network physician, your cost nothing. If you go out of network, let's say you want to see that one doctor right across town, and because your friend goes there and he does really good work or she does really good work, and so that's where you go over there, you get treated there, but that doctor is not in the network, your cost %100%. You have no coverage outside of the network. Within the network, you have no costs. You can go anywhere, but you pay more. Does that make sense? You see a gatekeeper first. The gatekeeper is the one that initially tries to treat you. If they can't handle it, then they send you to a network provider. No costs. But if you go out of network, you are responsible for everything. That is an HMO in a nutshell. It is simultaneously the most freeing healthcare coverage and the most restrictive at the same time. Really strange concept. At one point, my wife and I had HMO coverage. And it really is strange to be able to go there and have whatever you need done, and you never see a bill, ever. Yet, if you want to go see a specialist, like my wife needed her annual exams, she had to have permission from her primary care physician to go see a gynecologist. So, free and restrained at the same time. That's HMO. How's a PPO? PPO is what most people have. PPOs are very common. Let me rewrite that back on the board. Preferred Provider Organization. PPO. Preferred Provider Organization. Remember now, with an HMO over here, HMO, I'm just going to write some stuff here, and if you can't see, I'll be talking about it so you'll hear it. HMO has capitation. A PPO does not operate on capitation. A PPO works in this way. First off, they do have a monthly premium, just like the HMO. Capitation is fixed cost. A PPO has a monthly premium. I'm going to be doing a lot of writing. Monthly premium, and that's fixed, but they might have a copay, they might have a deductible, they might have co-insurance. What are those? If you have insurance, you don't know what those are. If you don't have insurance, or if you have insurance that doesn't have those, let me explain them real quickly. A deductible is generally a dollar amount that you have to pay, that you, the patient, has to pay before you have any coverage at all. Might be $100, might be $10,000. But whatever it is, you have a deductible, and that is out of pocket, out of your pocket first. We're going to go, oop, out of pocket. Then, you may have a copay. The copay is essentially like an admission fee to whatever service you're getting. For example, in my insurance plan, when I see my primary care provider, I have no copay. But if I go to an urgent care center, I pay $10. If I go to an emergency room, I pay $100. My primary care provider, $0. What does that fee structure do? What is that fee structure? What is it designed to do? It's designed to funnel me to the proper level of care. If I'm having a crushing heart attack, where am I going to go? Am I going to go to the primary care provider for 0 copay? No. I'm going to go to the ER. I'm dying. On the other hand, if I have an earache or a sore knee or a cough or whatever, if I go to the ER, which I can do, it's perfectly okay, I do not need permission, I'm going to pay $100 right there, out of pocket. These are also, out of pocket. If I go to the urgent care center, one of those fast cares that you sometimes see in stores, I'm going to have to pay $10. So, but those are your cost, not the companies that's providing insurance. This is what you pay. So that's copay. We talked about deductible and copay. What's coinsurance? A lot of plans have coinsurance, and what that is they pay the insurance company after you meet your deductible. The insurance company might say, we're going to pay 80% of the claims. You are responsible for 20%, out of pocket. Again, it's a way of sharing the cost to everybody. Now remember, with that HMO, no cost to patients. If they want a new iPod every time one comes out, they can get a new iPod every time one comes out. It's, in essence. Over here, you can still get a new iPod every time one comes out, but you're going to pay deductible, and then maybe a copay, and then the coinsurance. Most plans do have a maximum, a maximum out of pocket. And when you hit maximum out of pocket, then the coinsurance becomes 0. Now, maybe you already knew all this, but I told you all this to demonstrate the difference between the two plans. No cost with HMOs, very fixed cost for the businesses, but restrictive care. You can only see your primary care physician, who then allows you to see someone else. You may get very limited, focused. Let's call that. You may get very focused evaluations instead of a large, full blood panel and X-rays and everything else. So over here, it's more free. You can go see any doctor you want. If you have that knee pain, go right to the orthopedic surgeon. No problem. Of course, you got to pay your deductible, your copay, and your coinsurance. You want to go to the ER? Yeah, but you got to pay the copay. So what else is involved over here to control costs? PPOs also. I told you I was going to be writing a lot today, right? I hope that you decide to come this week to the Friday chat. This is usually a topic that needs further discussion. PPOs also have networks. HMOs have networks. Isn't that the same? Well, they both have networks. They do. One huge difference. Remember what happens over here in an HMO? If you stay in network, if you are in network, no cost to you. if you go out, 100% of the cost goes to you. Over here, if you are in your network, you have the standard coverage, your deductibles, co-insurance, all that. So let's just write standard dollars. If you go out of network, you have less coverage. Like, for example, if you're in network, you might have a $1,000 deductible. Out of network, it's usually going to be double. So you would have a $2,000 deductible. Does that make sense? I hope I'm not confusing you. But with a PPO, you can see any doctor and you'll still have coverage. You will have reduced coverage, but you will still have coverage. In an HMO, if you go out of network, you got nothing. Nothing. With a PPO, you go out of network, you will still have coverage, just not as good. There'll be more out of pocket. Now, over in PPOs are also called fee-for-service. Fee-for-service means doctors get paid for services. Fee-for-service. Over here, if you go to the doctor and have labs, x-rays, MRIs, exploratory surgery, colonoscopy, that HMO is going to get paid the same amount. Their doctors will get paid the same amount every month. If no one comes in that month, the doctors still get paid the same amount, and the HMO collects the same amount from the business. Fixed costs so that they know every month what they're going to be getting. In a PPO, a doctor that does a lot of procedures, more procedures equals more pay. Focused evals as a way to reduce costs. Sometimes extensive, because there is no constraint on the doctor. The more he orders, the more tests he does, the more he or she gets paid. So that is another difference. HMOs, PPOs. Now, were they the same? Both have networks. They both provide coverage within the networks. That's about it. So this was a lot of information. We're going to stop this section right now, but this is very important. Understanding the differences between an HMO and a PPO is really critical for you as nurses and you as consumers. Because think about it. If you go to the doctor and he or she wants to run extensive exams, you're going to have that deductible, the co-pays, and co-insurances out of pocket. as a whole, the entire country is paying more because so many people are using the system. There's no restrictions, there's no limitations on the system of using it. So there's no reasons for doctors to not do a lot of tests. Now, you're going to get great care both ways. You really will. An HMO has built-in safeguards to try to be conservative. So that's the big difference between HMOs and PPOs. Come back for part B. We're going to keep going because I tell you what, it just is going to keep getting better.